Welcome to the study of the month. Today, I will explain the first of 5 consensus statements from JCCI Congress on ceramic implant studies. Consensus statement number 1, using bone implant contact percent to determine the vertical bone loss. BIC percent measures the contact between implant and the surrounding bone, but since bone-to-implant contact percent is a measure only possible through histology, this consensus defines a vertical bone measurement for clinicians. This measurement should be done in specific time points. T0 immediately after implantation, T1 and T2 6 months and 12 months after implantation, and T3 3 years after implantation, suggested for randomized clinical trials. To control the vertical bone loss between consultations, a CBCT scan should be used. The accuracy depends on patient's immobility and using the same device for imaging and software for analysis. Discrepancies between radiological and histological assessments are less likely when the bone wall is thicker than 0.5 millimeters. To assess the vertical bone loss, first, define the most crestal bone at each side of the implant. The intersection between the long axis line of the implant and the mesial-distal line bounded by this most crestal bone at each side of the implant define the bone level, and it's this value that is going to be used for the vertical bone loss measurement in each subsequent consultation. Let's take a look together in a clinical example. In this cross-section, we will proceed with a mediate implantation in a region of molar lower jaw. A cross-section immediately after implantation. We define the most crestal bone at distal, the most crestal bone at mesial, and the intersection with the long axis line. T0, 11.37 millimeters. 12 months after the follow-up, a new cross-section showing also the most crestal bone at distal, the most crestal bone at mesial, and the intersection with the long axis line of the implant. T2, 13.27 millimeters. To use the vertical bone loss as a clinical outcome, we use the difference between the two values, in this case, minus 1.9 millimeters, showing that was no bone loss, but bone formation instead. The advantages of this technique is a reproducible analysis for clinicians. We can use even with bone augmentation after late or immediate implantation, possible with any type of implants, and avoid the inaccuracies with mean marginal bone loss. Next month, we will talk about the second consensus statement. Don't miss it, and don't miss it the JCCI 2024 this year to be involved with studies such as this one. See you soon.